Hello, everybody. Welcome back to the show. This is the Science Dispatch podcast. I'm Cameron English. That man over there, Dr. Chuck Dinerstein, Director of Medicine at the American Council on Science and Health. Chuck, I'm digging those glasses. It's got a very retro reporter kind of vibe. I like it.
Yeah, maybe that's kind of a Clark. I can switch over. I can go from my Clark Kent glasses to my Loving Spoonful glasses. These are
that little more of a lab rat kind of a look, like you just love messing with cells in a dish.
Lab rat, very nice.
Yeah, that's what you're going for. Okay, either one.
Well, the other ones I can use more to do that surgical. Well,
I got you. Yes, this is a troubling case. I agree. We must. All right. Well, we've got another Q&A episode for you all. Everyone has been submitting questions on our social media channels. We greatly appreciate that. And of course, if people have questions about science and medicine, that's ultimately what we're here to deal with. So we happen to have a doctor on hand who can speak to some of these issues with some expertise, because I can't, because I'm just a guy. But we're going to tackle two questions this week. The first has to do with the influence of genetics on heart disease, and then another one dealing with competing opinions among physicians and so on and so forth. That one's a little more involved. So let's tackle this first one. Chuck, I think both of these, there's probably a mountain of research that we can investigate. But the first one is pretty straightforward. Reader asks, is there a definite gene that can be isolated that causes higher heart disease in African-American populations? So higher rates of heart disease, presumably, is what they're going for there. What's your take on that?
So the answer is, well, a definite sort of maybe. There are 3 genes that have been found in people of African descent, which is not the same as saying black people, because those can be very different genetic heritages that are of interest. And actually, it was kind of interesting to look at it, and I'll talk about it in a second. But there is no clear single genetic predisposition for nearly all of the diseases that we think of as chronic illnesses at this time. So there is a gene that's actually fairly interesting, and it's TTRV1421, if you want to look it up in your books. And it's present in about 3 to 4% of black Americans from a study done on a large cohort of black Americans. And it does cause an earlier onset of heart failure and more hospitalizations, or it's been associated with an earlier onset of heart failure and more hospitalizations for those people that carry that gene. It's a little unclear what the cause of that is, and this is the gene that's responsible for that new treatment being offered, at least on my media feeds, for a new form of congestive heart failure, or TTR failure. So that's why it's related, obviously, to the gene that's there. There's been no difference in the mortality rates associated with it. And the best we can say at this point in time is that it causes a misfolding of proteins and results in some kind of an underlying inflammatory process that accelerates heart disease in black individuals. But there are other genes that may add to that, and if they're also present, they'll add more fuel to the fire. There's another gene that is responsible for the increased risk of hypertension in black Americans, as well as kidney disease. And both hypertension and kidney disease will, because of their underlying physiology, interact with the cardiovascular system and increase the likelihood of heart failure. So those are the genetic components. I would be remiss if not pointing out that there are, of course, lots of environmental concerns that also have a role. Probably the one that everybody will roll their eyes at that probably still is important is stress, because chronic stress does lead to increased release of epinephrine, which is going to leave you with a chronically increased heart rate, another factor that goes into causing some degree of heart failure. So there you got it.
I do always get a kick out of the idea that stress is a factor because it's real, but it's hard to mitigate, Like when people say, try to relax, you go, you can't try to relax. You're doing it wrong if you're trying to relax,
Well, it's like meditation. You can't not think about things.
Yeah. Yeah, it's a real challenge. And it's a great example of how it's hard to pin down a diagnosis or medical treatment when it almost seems nebulous. It's not, but it's just the tools that we have make it difficult to identify what's at work there. So based on what you said, is this a situation where it informs the care we provide? Because there's some cases with the influence of genetics, like when you talk about obesity, for example, we know there are gene variants associated with weight gain. But if you put someone on a diet that works for them and you help them develop an exercise plan, you can overwhelm whatever the genetic influence is on that, and they can lose weight. It's not easy, as we've talked about many times, but it's possible. So in other words, it doesn't really influence the treatment that you're going to go with. Even if you're talking about a drug like Ozempic or something, you can still treat it despite that genetic predisposition. Is that similar to what we're dealing with here?
It's similar, but it's an interesting problem for science and then therefore for policy. It depends on your outcome. So there was no difference in the mortality for individuals that had the genetic variant. So there was a clear difference in the number of hospitalizations and the onset. So if you look purely from a point of view of the big outcome, will you die sooner? Makes no difference. Don't need to bother looking for it. If you're counting beans and you're concerned about costs, then you want to identify those people right away because you know that those people are at greater risk, and you may kind of clamp down on them and trying to find some ways to get them to do the other physiologic or social mitigations to reduce that risk as great as possible. But then then you can have this fine conversation about, well, it's 4% of the population, and then we calculate what the cost of that extra hospitalization is, and then we figure their life is only worth $100,000 a week or whatever it is, and you get these papers that discuss whether it's actually worthwhile to screen for it. I think that it shows that I guess in some ways the more we know, the less we know. We know a lot more now about some genetic risk factors for congestive heart failure, but we're still kind of betwixt and between in terms of what's the best treatment now that we have that new information. I don't think there's a good answer.
So if time and money weren't factors, then this would be helpful. Otherwise, it seems that you have to consider it alongside all the other variables that influence people's health.
Right, many of the studies suggest that it's the social and environmental factors that play a larger role than the genetic ones. So that even having identified them, from some genetic study, unless you're going to change their environment for the better, that you won't have any. It won't do any mitigation either. So once again, a simple problem that we have absolutely no answer.
You're all welcome. The answer is a definite maybe.
Definitely. And I'll just say, because why not editorialize for a moment, this is one of the problems when you start talking about precision medicine. This is far more precise in terms of identifying people at risk, but you're left with the problem of, well, now what?
Yeah, genetics doesn't lend itself to easy answers. It can clarify, but as you said, it's more like, you read a philosophy book and you go, wow, I was so full of crap. I still don't know what I'm talking about, but I know more about knowing less. I think that's basically where we're constantly at with medicine. Okay, let's move on. Thank you for that question, by the way. Glad we could bring a little bit of fog to that very complicated question. And let's move on here, Chuck. This one's a little more involved, but still important. So, we got a name on this one, but I won't share it since we didn't get permission. But nevertheless, here's a question. When a patient sees so many specialist physicians who ping-pong us amongst themselves, who looks at all the medications collectively? How together they interact or impact as a whole? Please don't say PCP or pharmacy, because neither have done so. Why, after the Flexnor report, medicine is still so compartmentalized into body parts, treating symptoms rather than the core/root problem. And then the other on either of the two. Excuse me, that's not part of the question. Sorry. That was administrative note in my email. I just flubbed that up. Okay, so the question in essence then.
The question really is, how come medicine is so fragmented?
There you go.
Why isn't there one person that's going to be helping my ass out here?
There you go. Chuck getting to the bottom of it. Yeah, okay. Take it away, doctor. What's going on?
So the question is, I'll put it this way, is there a health Sherpa? No. There you go. Thank you for the question. So it's interesting if you dived a little bit deeper. The Flexner report actually, if you argue about it, is the proximate cause of the fragmentation, because the Flexner report copied
what is that, by the way, for people that don't know what the Flexner report is?
Oh, Abraham Flexner was this very lovely guy in 1910 that was tasked with the job of trying to figure out how to make medical school standardized and scientific. And he went off to the continent as on a junket and studied the best medical science of the day, which was in Germany. And he brought the German system of medical science home, which was basically the idea of physician scientists. You know, we would sit there and we'd examine the patient and then take a blood specimen and look at it under the microscope. You know, that more scientific version of Marcus Welby that we have, where you can still find somebody's doctor's offices that have some kind of microscope, I guess, like the stethoscope. They're just for show, as symbols of our careers. But the Flexner report broke diseases up into organ systems because that was the way to characterize things at the time. And we've really maintained that ever since. We've maintained that because we now have built upon that organ system differentiation board certification. You can be board certified in the heart. We call those cardiologists. You can be board certified in the pipes leading off from the heart. That's vascular surgery. You know, in the lungs, you can be a pulmonologist. So we board certify people in terms of organs. And we also, our payment systems are also based on those organ systems. We pay better for people that are concerned about our brains, for whatever reason. Though I am reminded of a great line from George Carlin, who said that the body was talking about which part was the most important, and the brain said the brain is the most important. But then he realized, look who's telling that to him. In any case, I've digressed. So we have a whole system that's been built upon that, and over the course of time, specialization has taken the place of the old family practitioner. In the period of time when Flexner was busy trying to standardize and make science on medicine on a scientific basis, the only care providers were private practitioners, family doctors that would make house calls. And that was supplanted in the 30s and 40s by doctors working in hospitals for a number of reasons. Most importantly is that the therapies that we had to provide were no longer available in our little black, boxes that we carried around with us from house to house. You needed to have an X-ray machine, which was tough to put in the buggy, and a wealth of drugs. So over time, science and the science of medicine has caused medicine to change. In family practice, while we still talk about it as an important idea, has slowly been dwindling in terms of the number in people going into it and the amount of remuneration you get for it. The only people that get paid less than family practitioners are pediatricians. And so again, while we honor our children with words, we do not honor their doctors and deeds in the same way that we honor primary care in words. We do not honor them in terms of payment. So ideally, it would be nice that your primary care doctor would provide some kind of overall view of your care. That's also been made more difficult by the advent of the computer and the electronic health record. That push came God, it must be 20, 25 years ago, to bring the computers and electronic health records to everybody. And the federal government invested millions and millions of dollars in that project. And at this point in time, 25 years later, the computer systems that were developed do not talk to one another. Amazon does a better job of communicating than any of our electronic systems. And we have new legislation before us now that they promise they're going to make all the systems talk to one another. But in the meantime, a primary care doctor may have patients that have records in any number of health systems, none of which talk to one another. So it becomes very difficult to provide that overall care. It's a shame, because that's really the best place to get good advice about what to do when you're facing a difficult situation as a practitioner who you have a history with.
That's interesting. I assumed, apparently wrongly, that most systems were on Epic now. So you would think there'd be some way for them to communicate, but that's not the case, you're saying?
70% of the established systems, yes, are on Epic. So as long as you've got an Epic doctor, that's fine. but your Epic system may not, then you get to your insurance company, and so my insurance company works through United Healthcare, so I have CVS. So my CVS pharmacy stuff may come over, but if God forbid I go pick up a drug somewhere else, Walgreens doesn't make it into the system. So it's those kind of minor annoyances that you would not put up with in any commercial system today that we have. I would also just say, now having blamed society and doctors, I would also say that the patients have a part of the problem too, is because more and more our patients want convenient care. I don't have any problem. I understand that completely. They want to get the care. They don't want to have to wait 6 weeks to come in for a sore throat. They don't want to wait 3 hours in the office. And so to a large degree, they've gone to the forms of healthcare that have been provided that meet those convenient needs, urgent care centers. But they do not have any kind of consistency in providing records to your primary care doctor. And this will be this is a boomer kind of thing, I have to say. But most people, until they're in their late 40s, have not had any real significant, bless them, interaction with the healthcare system. Having a hernia repair or breaking a bone or having a kid, we've medicalized it, but that's not the same thing as you got cancer or you have onset of diabetes. And therefore, you get plunged into a system that you have really no experience with and that you've not had any chance to build up a long-term relationship with anyone who knows your particular needs. And I think that's if I have to pick the greatest loss over my time as a physician, I think it's been that. I was blessed by being in a surgical practice where we had long-term follow-up. But, surgical care, most of the surgical care ends 6 weeks after you operate on them.
So it sounds like the massification of healthcare has really contributed to this problem. If I'm hearing you right, it sounds like my understanding is physicians get paid based on the number of patients they see. And so you have to, if you have to go through, okay. So if you have to bounce through one after another, you're incentivized to spend less time with them. And it would seem to me that would incentivize the sort of harmful division of labor you're describing, right? Like if you need to talk to someone about a complicated heart procedure or something, you're not going to try to break that down during an office visit. You're going to farm them out to someone who deals with that specifically, because that's very time consuming. Is that what you're saying? That
part of it is that kind of labor saving bean counter. How can I make myself? How can I make the person at the top of the ticket, the physician, more productive? And that's by bringing in other people, physician extenders or bots now, even better than physician extenders because bots never get tired, to perform some of these functions. But we lose something when that happens. I think that I would phrase this a little bit differently and say that this is what happens when you try to scale a craft rather than the benefits that come from scaling a commodity. So so in a lot of ways, what I considered the craft of medicine, which really gets down to the moments when you really need that doctor or that Sherpa, have been commodified. They've been commodified ever since the Flexner report first broke things down into organ systems, and we built a foundation upon that it's very difficult to unwind at this point.
So mass producing razor blades or records or some other good, it's not the same as mass providing healthcare, is basically what you're saying. Okay.
No.
Okay. All right. Well, again, I hope that clarifies things. Of course, we didn't solve the problem because it sounds to me like it would take a massive reformation of our healthcare system to address this in the long term. So is there anything you can do as a patient to mitigate this in any way? Are there certain services you could get somewhere where you would get better care one-on-one from somebody?
I think that early in your health journey, with those air quotes there, it's probably worth shopping around for a practice that you're comfortable with, that has a doctor in there that you're comfortable with, that you can see on a relatively routine basis. You get somebody that I'm just happy somebody to answer my phone calls now, to do that. But to find that person, I think is the key to doing that. There will be some disparities because you see the rise now of concierge medicine, which says for an additional $3,000, I will answer your phone calls. But not everybody has the ability to pay $3,000 or more for that on top of what the insurance covers.
All right. Well, there you go. Problem not solved. It's just the system's just so chaotic now. It just seems like there's not a great answer. But I hope that clarifies why things are such a mess to our listeners.
We're 2 for 2 on yours today.
Hey, man, that's what we're known for, solving the world's problems. Well, thank you for joining us, everyone, as always. If you have questions, post them on our social media. We're on Facebook, we're on X, we're on Instagram. Of course, you can always send us an email through the website. On X, it's at ACSH.org. On YouTube and all the other platforms, it's ACSH Matter of Facts. Our colleague Anna Delaski maintains those, collects your questions, posts short little videos answering some of these questions and commenting on the science and health issues of the day. So check that out, subscribe. We greatly appreciate your support, and we will see you next time.